Hi everyone, our subject today is neonatal skin disorder. Introduction. Many newborn skin eruptions are benign and self-resolving. Proper diagnosis and understanding of the natural history of these entities can often help alleviate parental concern. How to approach to child with physical and bodily perform a history and physical examination. If it is presented within 1 to 2 months of age, this is our subject today. If it is yes, if it is generalized distribution or localized. If it is localized, differential diagnosis may include malaria, sucking blister, bullous impetigo, herpes simplex, localized, lymphangioma, aplasia cutis congenita, acrodermatitis enteropathica. If it is generalized, differential diagnosis may include Erythema toxicum, transient neonatal pustular melanosis, herpes simplex disseminated, congenital candidiasis, congenital varicella, staphylococcal skin syndrome, epidermolysis bullosa, incognita pigmenti, and other rare blistering congenital dermatomes. If it is older than 2 months of age, it discussed in previous lecture. Disseminated herpes simplex virus. A generalized vesicular exanthem can occur in disseminated herpes simplex virus infection of the newborn. Lesion associated with localized infection involving only skin, eyes, and mouth may be subtle, but diagnosis is critical because localized disease in this infant can progress to encephalitis or disseminated disease. PCR test and culture are diagnostic options for herpes simplex virus. Zinc smear are of limited usefulness because they are not very sensitive, plus will not distinguish between herpes simplex virus and varicella. Incognita pigmenti. It is a hereditary disorder with a multi-system involvement. It mainly affects female. Cutaneous manifestation develop in the first 2 weeks of life, with a red streak and crops of vesicle or bully developing on the trunk or in a characteristic linear distribution on the extremities. Evolution to verrucous lesion followed by characteristic pigmentation changes subsequently occur, usually by 4 months of age. Blister may reoccur later with the febrile illness. The hair, eyes, CNS, and teeth are also affected. Sebaceous hyperplasia. Pinpoint yellow-hued papule on the forehead, nose, upper cutaneous lip, and cheeks of full-term neonates. Gradually disappearance within several weeks of life. Neonatal cephalic pustulosis, neonatal acne, erythematous papules and pustule on the forehead, nose, and cheeks of the newborn. Typically develop in the first month of life. They lack of comedone, blackhead, whitehead, and or acne cyst. Distinguish neonate cephalic pustulosis from true infantile acne. Natural history. Develop in approximately 50% of newborn. Malassezia species yeast contribute to eruption. Treatment is usually not needed because lesions spontaneously resolve. If treatment is desired, consider topical azole antifungal cream. Milia, superficial, small, half to 2 mm round white papule, most often on face, gingiva, or palatal of neonates. Epistean pears, milia on the mucosal palate in neonate. Bohon nodule, milia on gingiva in neonate. Natural history. Milia typically spontaneously rupture and resolve with no complication. Associated disease. In rare genetic disorder, newborn may have numerous or persistent milia. Miliaria Crystallina, tiny, half to 1 mm clear, fragile superficial vesicle No associated itching or pain. Natural history, superficial blockage of the eccrine sweat duct in the skin, occur in context of overheating, often with the swaddling. Resolve spontaneously once triggering conditions are corrected. Sucking blisters, one or few isolated blister bully or avoid superficial eruption with no surrounding erythema on the upper extremity of healthy newborn. Common location, thumb, radial forearm, first finger. Natural history, induced by infant sucking of an accessible body part in utero. Sucking blister resolve quickly with no complication. Supportive wound care is indicated. Transient neonatal postural melanosis, present at birth. Three different characteristic skin lesion. Small, fragile, superficial pustule with an erythematous base. Small, colorate of scale at site of ruptured pustule. Small, hyperpigmented macule at site of former pustules. Commonly involved anatomic sites include forehead, chin, trunk, posterior scalp, and extremity. Palm and sole may be involved. Expressed pustules show numerous neutrophils but no bacteria on gram stain. Culture from pustule are sterile. Natural history, more common in full term versus premature neonate, and in black 5% versus white infant less than 1%. Pustule generally lasts 2 to 3 days, and hyperpigmented macule often persists for several weeks to months. No treatment is needed, lesion self-resolved. Erythema toxicum neonatorum, scattered 1 to 2 mm white to yellow papules or pustules over splotchy irregular erythematous macules, mostly on the trunk interneonate. Spares palm and sole. Eruption is not present at birth. It typically appears within 2 days to few weeks of life. Expressed pustule dermatome demonstrate numerous eosinophils on right stain. Culture from pustule are sterile. Natural history occur in approximately 50% of full-term neonate, rare in premature infant. No treatment is needed. Lesion self-resolve generally in 5 to 14 days. Congenital cutaneous candidiasis, eruption develop within first week after birth. In term infant, congenital cutaneous candidiasis present with the widespread erythematous macules, papule, and pustule with superficial scaling. Palm and sole may be involved. Nail may be thickened and yellowed. In preterm and low birth weight infant, congenital candidiasis may present with the erosive dermatitis and is often invasive with multi-organ disease. Natural history, ascending candida infection, premature rupture of membrane may be subclinical. Treatment, consultation with infectious disease service is advised. In a healthy term neonate, congenital candidiasis, skin lesion but no other symptom, watchful waiting or topical antifungal treatment may be reasonable. In premature infant, systemic antifungal are generally recommended. Seborrheic dermatitis, cradle cap, greasy yellow scale on scalp with no hair loss, pink erythematous, patchy in neck, axilla, and inguinal folds. Natural history, most often develop by approximately 2 to 3 months of age, tend to resolve by 12 months of age. Malassezia species yeast contribute to eruption. Disease association, infant with Langerhans cell histiocytosis may present with the seborrheic dermatitis-like feature. Consider Langerhans cell histiocytosis as a diagnosis in infant with the seborrheic dermatitis who fail to respond to topical treatment, have petechia in the skin fold, or demonstrate other concerning signs such as copious ear discharge or excessive urine output. Treatment of infantile seborrheic dermatitis is not necessary. Scales from scalp can be removed with a mineral oil and soft toothbrush. Antifungal shampoo or cream may be helpful in this mild eruption is bothersome. In more troubling or symptomatic cases, low-potency topical steroid in ointment or oil base may be useful treatment addition. Avoid use of olive oil because it may potentially worsen the eruption by fueling Malassezia species yeast. Acropustulosis of infancy, infantile acropustulosis. Cyclic eruption of pruritic papule and vesicle on the palm, sole, and lateral aspect of palm, sole, and digits. Natural history. Typical age of onset 2 to 10 months of age. Episode during which a new lesion develops generally lasts 1 to 2 weeks. Recurrent cyclic episodes occur every 2 to 6 weeks. The time in between eruption may gradually become longer as affected children grow older. Around age 2 years, episode generally ceased. Disease association, possible association with the preceding scabies infection. Treatment, high-potency topical steroid and oral antihistamine help alleviate itching. If there is concern for scabies infestation, consider therapeutic trial of topical scabicide. Diaper dermatitis. Irritant diaper dermatitis erythematus, moist, patchy and or scale on convex surface of buttocks and genitalia. Candida diaper dermatitis, beefy red erythematus, moist patches involve skin fold as well as convex surface in diaper area. Satellite papule and pustule are common. Natural history, skin exposed to excessive moisture in a diaper area is prone to decrease skin barrier function, friction damage, irritation from urine or feces, and yeast superinfection. Treatment. Diapers should be changed promptly when wet or solid. Diaper area should be cleansed properly with the gentle soap or cleanser. Frequent application of barrier, ointment, or cream is recommended. If candida infection is suspected, treat with anti-yeast, antifungal, topical cream twice daily until clear. Cutis marmorata, widespread, lacy, reticulated, mottled red-blue skin discoloration in newborns. Eruption exacerbated by cold temperature. Natural history, skin finding result from physiologic vasomotor reaction to cold in neonate. Vasomotor reactivity diminished with age. Disease association, although common in healthy newborn, pronounced cutis marmorata may occur in the following condition: Down syndrome, trisomy 18, Cornelia de Lange syndrome, Menkes disease, and familial dysautonomy. Cutis marmorata telangiectatica congenita, CMTC, fixed reticulated vivacious atrophic plaques which are often limited to one or few segmental area on extremities. Lesions do not improve upon exposure to warm temperature. Lesion may ulcerate. Lesion may be associated with hypoplasia or hyperplasia of the affected limb. Natural history, considered to be type of sporadic congenital vascular malformation. Lesions tend to fade and improve with time. However, affected children should be monitored for limb asymmetry or other complications. Birthmark. Benign birthmarks are very common. However, it is critical to recognize birthmarks that may be associated with the other medical conditions. Dermal melanocytosis, Mongolian spot, blue to gray macules and patch that are most commonly on the presacral skin and buttocks but may occur on shoulder, back, posterior thigh or extremities. Natural history: approximately 80% of Black, Asian, and East Indian infants are born with the cutaneous dermal melanosis, whereas the incidence less than 10% in white infant. Dermal melanocytosis lesion located on the buttocks or presacral area tend to spontaneously fade in the first few years of life, whereas lesion in a less typical area such as on extremity may be more persistent. Disease association: most commonly dermal melanocytosis is uncomplicated. However, extensive dermal melanocytosis may be present in children affected by Haller syndrome, mucopolysaccharidosis type 1, and GM1 gangliosidosis. Nevus simplex, salmon patch, light pink, blanching vascular patch or patches, most often on the glabella, upper eyelid, occipital scalp, and or nape of the neck of healthy neonate. Natural history: pink discoloration is typically more notable with the crying. Lesion on eyelid and glabella often disappear in a few years, but large lesions involving most of the central forehead and those on the posterior neck tend to persist. Capillary malformation: port wine stain, nevus flammeus, erythematous to violaceous non-blanching fixed patches, present at birth. Natural history: may occur on any skin site, do not fade with time, may thicken or develop vascular blips over time. Diagnosis and evaluation: although many capillary malformations are uncomplicated, special evaluation is indicated in the following situation. Capillary malformation affected the forehead and or eyelid may be indication of Sturge-Weber syndrome, which is a constellation of facial capillary stain affecting the forehead, ipsilateral glaucoma, and ipsilateral leptomeningeal angiomatosis. Sturge-Weber syndrome can be associated with seizure and developmental delay. Affected individual should have an eye examination to rule out glaucoma, and a careful history and neurological examination should be conducted. Early MRI in the neonatal period is controversial because it does not rule out the condition or change short-term management. Isolated preocular capillary malformation can associated with the ipsilateral glaucoma. Ophthalmologic examination is warranted. Extensive capillary malformation on the extremity may indicate Klippel-Trewanny syndrome. Klippel-Trewanny syndrome is characterized by capillary malformation, musculoskeletal overgrowth, and venous malformation. Clinical concern include cellulitis, lymphedema, deep vein thrombosis, and leg length discrepancy. Treatment: capillary malformation can be lightened with a series of pulse dye laser treatment. Referral to dermatology is warranted. Infantile hemangioma are uncommonly noted at birth. Most lesions become apparent as they proliferate between 2 weeks and 3 months of life. Congenital melanocytic nevi present with the light brown to dark brown or black macules or barely elevated papules, which may have geographic well-demarcated border or speckled pattern interiorly. Nevus depigmentis, well-demarcated hypopigmented patch or macule present since birth. Natural history: Although a congenital lesion, nevus depigmentus, may become apparent as the infant's pigment increase over first year of life. Disease association. Tuberous sclerosis should be considered when the 3 or more hypopigmented lesions are observed in an infant. Nevus aminicus is pale hypopigmented patch in infant caused by local vasoconstriction in skin, which can be exaggerated by vigorous rubbing edge of lesion. Additionally, edge of an nevus aminicus can be blurred by pressure with the glass slide. Natural history. Catecholamine hypersensitivity of affected tissue cause local vasoconstriction, resulting in the pale appearance. Disease association. High prevalence of nevus aminicus in neurofibromatosis type 1. Caffeolate macules, well-demarcated tan macules or patches. Natural history, gradual, proportionate growth with the child. Disease association, multiple caffeolate macule may be associated with neurofibroma type 1. Large cost of main caffeolate macule may be associated with McCune-Albright syndrome. Thank you for your listening.